Okay, hello everyone, and welcome to today's virtual panel discussion brought to you by Indiana Healthcare Executives Network. My name is Vishwa and I'm your session host representing the National Office of ACHE. We are so glad you're here, but before we get started, I want to go over a few items to help you navigate the program. For the purposes of noise control, your lines will be muted for the duration of the session. The chat function will be available to you throughout the entire event, so please utilize it to ask any questions or place any comments you have. The Q&A portion will happen after the panel presentation. The event is being recorded and will be available for viewing in the ACHE Learning Management System in approximately 2 business days. Today's session is worth 1.5 hours of ACHE face-to-face credit. To earn this credit, you must be logged in for the entire duration of the event. All attendees who meet that requirement will have their credits applied within 2 weeks from today's event. Lastly, we do encourage you to complete the evaluation for this event. The link will be in the chat box shortly, so please visit it before we close out today's session to leave any concerns or comments you might have so that we can improve our sessions going forward. Now, to begin, let me turn it over to Rodney Hollis.
Good morning, everyone. Thank you for joining us for this wonderful program that we have for you today. Before we get started with anything, I wanted to take time out to thank our sponsors, because with their support that we can provide such programs as this to our members. So I want to say a special thank you to Ice Miller for being a premier sponsor. I also want to thank Hebe for being a platinum sponsor. Thank you to our gold sponsors, InnoCare, Arc Design, Cornerstone, and Cat Sapper and Miller. Again, thank you for all of your support. Now, before we dive into our program, or the discussion portion of our program, I have a quick procedural thing that I need to go over with you guys. We need to approve the 2022 board slate for our IHEN chapter, and this is exciting. So I'm going to share my screen, or Corey, can you share your screen and show the board slate?
Is it not up?
Yep, it's up. So we have Sri, we have Angie Stevenson, Andy Van Zee, Terrence Stone, and Alex Simonton on our 2022 board slate. Are there any oppositions to our slate? I will take your silence as confirmation for our board slate. So again, I see a note. Happy to approve all these. Thank you, Sheila. Again, this is very exciting. I'm looking forward to what 2022 has to offer for our board. And we got a lot of cool, fun, exciting things planned for you guys in 2022. So definitely stay tuned. We'll go over some of that at the end of this meeting as well. So I'll definitely be sure to stick around for after the discussion and the Q&A portion of this meeting. So with that, let's dive into our program. So thank you again for joining us. We have an amazing and well-rounded panel before you today to discuss equity of care in the healthcare delivery system. We have our moderator, Dr. Lauren Dungy-Poitras, from Associate Professor of Clinical Obstetrics and Gynecology with the IU School of Medicine. We have Tracy McInnes with IU Health, and we have Dr. Virginia Kane, Director of the Marion County Public Health Department. This is an exciting program and you guys are gonna enjoy this. So again, thank you for joining. With that, I will hand it over to our program moderator. Lauren, it's all yours.
Thank you, Rodney. I'm certainly excited to be here to talk to this group, and I'm very honored to be here with the distinguished panel members that are also here. And we'll just dive right into it. We'll start out with question number 1. Actually, in reviewing a project that I recently had to review, I came across the Healthy People 2020 goals. And one of those aspirational goals was to create social and physical environments that promote good health for all. Yet, we unfortunately know that that is not indeed the case that we have today. We have vast inequities in healthcare that we see and face daily. I face, as a maternal fetal medicine specialist, inequities in infant and maternal health. Unfortunately, similar to so many other health disparities, Black infants die 2 to 4 more times than whites before their first birthday, and Black women die 2 to 4 times more in the first year after giving birth than white women. In fact, the Black maternal mortality rate is one of the greatest of all the race disparities in women's health. When compared to white women, Black women are 22% more likely to die from heart disease, 71% more likely to die from cervical cancer, and 243 times more likely to die from pregnancy or pregnancy-related causes. Unfortunately, some of these factors we all know are related to health disparities for people of color that extend outside the personal health and of the individuals involved. And they extend to the social and physical environments that they live in. Tracy, I'm hoping that you can speak to some of the most pressing inequities within your area of expertise in mental health. I think you're on mute, Tracy.
Thank you for that. My name is Tracy McInnes. I run the postpartum depression program for IU Health here in Indy. And I would say the underserved population here in Indianapolis, just not having as many options. So I see private insurance patients being able to get in quicker for therapy, quicker for psychiatry. And so that is something that we really see as an inequity. We just don't have as many providers to begin with who accept Medicaid as insurance. And so these people are waiting so much longer for appointments if they even get there. Transportation is an issue, obviously. And then of course it moves into medication and all the different things that go with that, and trying to get people medicated for postpartum depression, anxiety, OCD, post-traumatic stress disorder. So that is probably the biggest thing I have seen, is just access to care based on insurance for now. And the need is so high during the pandemic.
Thank you. Dr. Kane, can you address some of the pressing inequities within your realm of involvement?
Definitely. I actually chaired the Indiana University Simon Care Center Cancer Advisory Committee. So we look at different issues across the state of Indiana. And just to give you an example, Gary has the highest cervical cancer rates in the state of Indiana. And when we looked at healthcare delivery services there, even though we have multiple hospitals, they have lost their oncologists in the city of Gary. So for patients who may need follow-up chemotherapy or other services, they either have to travel to Murrayville, Indiana, or they have to pray they can cross the Indiana line and a Indiana hospital or oncologists in Illinois will take their care. And so what does that mean for vulnerable populations? Well, they have to take the bus. And to take the bus over to Maryville takes at least a minimum of 1 hour. And heaven forbid, if you're doing traffic time, then it's at least 2 hours. So that means for a person going to see an oncologist for a normal trip, you're talking about 6 hours out of their day. It's like almost a whole day. And then even despite that, depending on your insurance, I think they can have a limit of how many people they accept who have no dollars, no money, or are on Medicaid reimbursement. So that's just That's just one of the issues we face, that they've actually come down to get their chemotherapy starting out in Indianapolis at the cancer center, but they can't continue to come down for their chemotherapy. You may need 6 treatments. And someone's got to monitor your blood counts, making sure you're not becoming what they call neutropenic, where your white blood cells are so low, you have to get medication and treatment for that. And so just to even look at all their cancer rates, I'm just not even talking about cervical cancer. It's so terrifying to look at the breast cancer rates that are occurring there. And Lauren, I want to talk about infant mortality. So there are so many providers across the state of Indiana do not accept Medicaid reimbursement. They feel that that reimbursement does not meet their costs. So if it's not meeting my cost, I'm not going to take care of you. And so it's an enormous challenge where we have to try to see if we can place strategically federally qualified community health centers that may be able to negotiate rates with a OBGYN provider in order to provide a primary care. And let's face it, with this pandemic, we had to do what's called telehealth. And let me ask you, for someone who may be homeless or someone who can't afford the internet connection, how do I talk to my provider? How do I get in to be screened, or someone's monitoring my hypertension or monitoring my diabetes? You know, we used to have our frequent flyers, is what we call them, for diabetes. Well, whoa, you know, when we shut down our emergency rooms during this time, you know, you couldn't hardly get in there unless, you know, you were dying. So we have incredible gaps, unfortunately, in the state of Indiana, some more than others.
You make some very, very good points, Dr. Kane. I will tell you that I had a patient who I was doing a virtual consultation with, who had the technology in her phone to do that virtual visit, but she had to do it at work, which was a Burger King at lunchtime, with people and noise all behind us. When I asked her to step outside so I could understand her, she lost her internet connection and we lost the ability to have that consultation. So you make some very good points that are issues for people, and particularly in rural areas that may not have access to care. During our prior conversations, we had some discussions about bias and microaggressions. And I know at one point we asked for a few examples, and it occurred to me last night when I was talking to my daughter that I have a perfect example of a microaggression. When I first joined IU, I went to one of the local hospitals and I walked in with a suit on, and this very pleasant white woman came up to me and said, could Alfred to help me find what I was looking for. And I told her I was looking for the doctor's lounge. And she paused and looked at me and said, well, the doctor's lounge is only for doctors. And I just looked at her. And then she looked at me and said, are you a doctor? And I said, yes, I am. But for some reason, there was something about the way I looked that didn't give her the impression that I was a doctor. And as I was telling my daughter last night, Maya Angelou has a quote that says, people may forget what you say, but they will never forget how you made them feel. And that's what I told her microaggressions are. Nobody's going to blatantly say, well, you don't look like a doctor. Who are you? They're going to say things that make you feel offended. And I had to laugh because there's a chaplain at one of the hospitals that I work at that, you know, I tell him the Bible says love is not easily offended. And I have to consciously not be offended on a daily basis when I come to work. So I wonder if you, Dr. Kane or Tracy, have any examples of bias or microaggression, or perhaps related to pain medication and treatments and ERs, or things that you'd like to address. And I see you grinning, Dr. Kane. Why don't we start with you?
Well, I have to tell you, I'm going into the football business because I have an incredible football player that I've been trying to get the coach to hire.
Okay.
My little kitten tackled me, tripped me on my second floor of my house, and I fell down a long flight of stairs, and I herniated my L3, my L4, L5 of my back. I tore my medial lateral meniscus of my right knee, and I didn't even know it because I was in so much pain from the back and the knee that I had torn my right rotator cuff too in the same process. And this is about 3 years ago. I had 3 surgeries in 1 year. And I was in such intense pain. And, you know, they got me to the emergency room. I was placed on pain medicines and everything. But I will tell you, the pain medicine that they placed me on was one pain medicine and a muscle relaxer. But I was fine if I did not move. If I tried to move, then that pain was just be so unbearable. So I said, wow, I got to get into my doctor. So I called to get an appointment with the doctor. And of course I couldn't reach him. So they have the nurse come on to try to handle your calls. And I said, well, listen, I think my pain medicine is not holding me. I need to get to see, to get in to see the doctor right away. And so she immediately implied and told me, well, you know what? The doctor doesn't really like to increase the pain medicine and blah, 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 blah. And so I don't know if he's going to be able to see you and blah, blah, blah. And of course, I never use my name as doctor. I like to see how people treat me without knowing whether I'm a doctor or not. And I said, well, I can understand that some circumstances that happens, but I have to tell you, I'm in intense pain. And if you just I knew the doctor knew who I was. If you just talk to him and then get back to me whether I can get that appointment with him today, just let me know. And I do appreciate the advice you gave me about the pain medication. Now, what was crazy about it was, and whether this was right or wrong, the emergency room gave me the low starting pain medicine dose, and maybe that's what they're supposed to. So I wasn't even at the full strength for this one particular pain medication. I wasn't even close. And after they looked at my MRI, they said, well, I don't understand how you could even make it in here. And I said, you're right. I died with the pain just getting to see you. It was so bad. So I had to get a steroid shot on the spot to help, I guess, reduce the swelling and everything, plus finally up my medication appropriately. But I think this unfortunately happens more to African Americans or Black patients compared to our white counterparts.
Do you have any comments to add to that, Tracy? You're still on mute, Tracy.
I have an experience I can add personally where I was on the other side of that. I worked for Healthy Families, which is a child abuse prevention program, for 19 years prior to this role. And in those 19 years, I really saw just the inequities with my patient population, underserved, people of color. And so many times I would see myself at the ER with my patients. We would be treated very differently by providers. And then my own baby, 2 years old, fell and broke his arm. And we went to the emergency room, and I, having that background, that experience, that lived experience, was waiting. My husband and I should have been separated. We should have been talked to about what happened to our 2-year-old with this compound fracture. We were never asked. And so I, having again lived that experience many times with my patients, asked, why are we not being asked what happened to our baby? He has a broken arm. And of course, everybody kind of back on their heels a little bit. But it was so interesting and so concerning to me that we can walk in as a white middle class couple with our little boy who was at a sitter and just fell off the slide and broke his arm. And that was good enough, when I had seen so many times how that story was never good enough. People were separated, no dignity, child removed from DCS. So that's just an experience that I think explicit bias and microaggression, in my opinion.
Indeed, I appreciate that comment and your stance on that. It reminds me of a situation with a pediatrician that I know who told me of an instance of a Black female who had brought in her child who had some kind of pigmentation or something changed in the eyes, which is not uncommon with babies. And they labeled it as a concern for shaken baby syndrome, and CPS was involved, and it was just a normal finding. And all the things that this woman had to go through to just maintain care of her child. So thank you for sharing that. I appreciate that. Let's go on to the availability of services and methods used to provide healthcare services to patients. We know that sometimes they're very challenging. For example, Tracy, I know that as you mentioned, finding services for Medicaid insurance is a challenge. What are some of the methods that you might have utilized to help strengthen care delivery to vulnerable populations with mental health concerns during this past pandemic as well as in the past?
Yeah, so originally, so pre-pandemic, probably about 6 months pre-pandemic, I'd seen a need for underserved population having a support group for perinatal mood and anxiety disorders. I was coming into the position, there was one, I noticed that just the people that would come to group all looked very similar and all were kind of in the same socioeconomic class. So I decided, again, with that Healthy Families history and that passion to help the underserved, where are the other women going? So there wasn't such a thing as a group where they would feel comfortable, where we would meet their needs. And so I created a support group in the inner city on the bus line, provided a meal to the mom and the child, childcare for the younger children, diapers and wipes, goodie bags, all the things that would have, lead to a successful support group for people who did not have this in place as it stood. And so we did that prior to the pandemic. And then of course, at the time of the pandemic, I tried to go virtual with that support group as well as the other support group I run, and it was not effective. And again, back to kind of what Dr. Kane said, the lack of technology, the lack of access. If we don't have a home, or certainly, a virtual support group is not something that's on my radar. It's feeding my children, it's getting a home. And so that was really unfortunate for me, but it really shone a light on the, again, underserved population and how with the pandemic having to go virtually. And that was really concerning because there were it was 6 months in, we were really starting to create a bond in that group. And we were really starting to get into what the difficulties were that those families were sharing, and for that to just kind of almost disappear. So I followed up, but even following up with them, I didn't get a hold of everyone. I don't know the outcome, and just such a shame. And I think that answers that question. I'll stop there because I have more, but it's about another question. So
I can imagine, and that even with some of the internet and privacy issues, there might even be some trust issues related to trying to maintain a support group online.
And also abuse in the home, Lauren. Abuse in the home is going on, and we don't think about it, but sometimes turning on a computer is shining a light on what may be going on in the background. And so I think a lot of that has to do with living in the poverty culture and that not wanting to be, even if they have the technology.
Absolutely. And I've been involved in just, what do I call it? Uplifting programs or support groups for young girls. And to realize a lot of them, I don't want to show you my house. I don't want to be on video. I'm happy coming to groups. I'm happy talking to you. I want the support that you have, but I, for whatever reasons, don't want you to see the inside of my house or be a part of what's going on inside of my house. I also appreciate your attention to mental health. We know that throughout this pandemic, there's certainly been increased concerns. I know that our CEO wrote a letter to the employees stating how they have recognized the need for increased mental health services and are promoting that for both employees as well as patients. And that was encouraging to see. Dr. Kane, perhaps you could speak to some of the reimbursement issues and the supply of healthcare professionals for these vulnerable populations.
Well, one of the things is, wow, we saw an incredible number of people who are in the working industry. Let's just give the example, hospitality, who when everything shut down, restaurants closed, we saw a significant number of folks on the front lines and didn't have the ability of, having funding to pay their rent, even concerned about their utilities, heaven help us if they had child care services that they needed. And so when we look at things like that, we look at, wow, I've got to decide if I need health care, can I afford the medications or not? What's more important, buying that medication or at least or making sure I've got electricity in my house or food on the table? So we have tried to offer services where it's not so cost prohibitive for the individuals who have no dollars or they don't have any good income coming in. So we have such programs where you can come in and get your immunizations. And we have an administrative fee of $20, but hey, you don't have that $20, we give you an envelope to say when you hit the jackpot, Powerball or Mega Million, I want you to remember us, send us that money back. But services such as sexually transmitted diseases, or we're having a little syphilis epidemic going on right now. In that arena. And listen, we saw that the homeless has like 2 to 3 times the risk of acquiring coronavirus and being able to spread it to other people. So we developed and went into the homeless business, housing our homeless who are infected with coronavirus in hotels, and looking on them to provide medical care while housing them. We're still housing them to date. And we're, so how do you bring in and strengthen these healthcare delivery systems? But one key critical, I think all of you in healthcare has got to understand, if we can continue to do the medicine through the traditional way, we will not be effective in improving health outcome. We have got to address social determinants with our patients. And so in some of the hospital systems and healthcare systems are doing it, just like for prenatal care, Lauren, patients can call and get transportation to make it to their appointment. But there are problems sometimes with that. And so we're trying to be more innovative so that a patient doesn't have to call a month in advance for their appointment, and they're late for their appointment because the taxi cab driver didn't pick them up on time, because I assume, hey, I got a better ride paying me more money than me picking up this client. But I think until we address social determinants, terms of transportation, and guys, I know you're not going to want to hear this, but I'm going to tell you this anyway. This deal about for special populations that you have, if you're not here in the 15-minute grace, I got to reschedule your appointment. So tell that to the mom who's pregnant, waited to get on the bus, took her an hour to get to her appointment by the bus. Heaven forbid if it's in the winter months and it's snowing, and I make it 16 minutes after my appointment, ma'am, you got to reschedule. So we got to figure out, based on the environment of what our patients are experiencing, how to adapt and address what's happening from a realistic standpoint, sometimes in certain settings with our patients. And I want to talk about the implicit bias that I've seen too with some of our patients. I had a young lady, she had 4 children, and her children were from multiple fathers, but she had a newborn baby, 6 months old, but she had a bacteremia with a bacteria in her bloodstream that needed to be treated through an IV therapy. And when she was told that she's going to have to stay for 10 days, she says, I can't stay for 10 days. I don't have anyone to take care of my children. And I said, you know what? You won't even have to worry about your children if you don't stay, because you're not going to probably be here 10 days from now. And so she says, well, okay. I have a 6-month baby. I know I can get the mother of my husband to take care of 3 of my kids, but they're not going to take care of the 6-month-old baby. I need to talk to my girlfriend about this, but she's about to go on her vacation trip. And I've got to see if I can talk her into taking care of my 6-month kid and delay during her vacation. So, but I can't do it here in the hospital. So she had to sign out AMA.
Mhm.
And so what happened was, but when you looked at the documentation from the providers in her case, they implied that she was a non-compliant patient. She was terrible. So anybody coming to take care of her later, she's already labeled as, being incredibly stupid because she signed out AMA. And I said, guys, you didn't even tell the true story in her patient chart. You have labeled her because you're mad because she left AMA. Well, guess what? She got a girlfriend to take care of her 6-month baby, and she was back in 4 to 5 hours, like she said she was going to be. But we got to be careful how we document what happens to patients and what's the result of our documentation, because it was inadequate, what we explained in there, versus, so you get a different picture of her.
I think that's so true, Dr. Kane. When I was in Cincinnati as a fellow, I had the residents come up to me and say, there was a patient who was diabetic, and they said, she says she can't stay. She was out, her blood sugars weren't in good control. She says she has to leave. And they documented that she refused to stay. She has to leave because she has to go pick her child up at the bus stop. I said, you are darn right. She has to go pick her child up at the bus stop, and then she can come back after she does that. I'm not going to leave. I wasn't even married or had children at that point, but we're not going to leave a child standing out at the bus stop wondering where their parent is to pick them up. And so just some grace and some understanding, and that, not everybody can comply with the way we expect to. We also have the issue oftentimes that the government supply at that time they called them food stamps would run out at the end of the month, and this moms would choose to feed their children than to feed themselves. And so we have to adjust and understand the demographics and the structure of what our patients are going through to properly treat them and improve outcomes.
But one last thing, I know people understand this about strengthening their care to vulnerable populations. We have had to, I know you guys have had some staffing shortage issues. So I've lost tons of nurses, medical assistants in my operations. And so I have had to go and contract with additional organizations to try to provide my staffing. I am in the process of signing my 3rd contract with a 3rd organization in order to try to find more nurses, more medical assistants in order to carry out my operation. We've had a lot of burnout during this pandemic. Some people said, hey, I have to be able to stay home and take care of family members. I don't have the luxury now to be able to work out on the front lines with a very contagious and maybe life-threatening virus. And so it's been huge. But, and this is the first time we've done that.
Thank you. We often hear the phrase cultural competency utilized in our professions, and building cultural competence is an ongoing process. It requires intentional and continuing efforts, as well as engagement at multiple levels throughout an organization. Dr. King, can you share with us some information regarding the educational offerings your organization is providing or has provided to your staff in order to develop skills and cultural competency?
So in the last 5 years, we've seen an influx of a number of immigrants to our city, our Burmese population, a number of folks from Africa, and where English is not their primary language. And so sometimes things that we may do from a cultural standpoint may be offensive, and even African Americans, Black African Americans, simple things like I'm calling somebody by their first name, and you may even have we had a young lady. She was over one of our major pharmaceutical companies. She was the state manager for that. Had a master's in neuroscience, just smart as heck. And to have people come in and talk to her as though, just even like talk to her as though she needed communications at a 3rd and 4th grade level, calling by her first name without her permission, and just how she and her family felt insulted because her husband was a PhD at, I won't say one of the leading, and the department head, one of our leading companies here, and I think his PhD was in chemistry. And so to be there in the room, to have someone come and talk to you like you don't understand what's going on, because it's obvious they didn't read the entire chart or the critical parts of the chart, or even asking for that information before they started the communication to try to understand the level of understanding a person has or not. So we've been doing cultural competency trainings, having people from these same cultures to come and say what their experiences have been and why they felt that they were being insulted, and even related to from a sexual orientation standpoint or transgender patients or whatever. And so it's not that we're trying to do it intentionally, be insulting, but you don't even realize when you're insulting. And that causes that trust level with your provider and your expectation that they're going to follow your recommendations when you don't even know. It's the diabetic patient who is having a provider tell him, now, sweetheart, you got to follow your diet. You got to eat these things, and you're not going to have a healthy outcome unless you're not doing this right. And so I'm not seeing where you're getting all of your vegetables and blah blah blah. And the patient is looking at him like, hey, there's not even a grocery store in my area. You talk about food insecurity. The closest I have access to is a 7-Eleven gas station. Don't have any vegetables, don't have any fruits. And you're trying to chastise me, lecture me, being paternalistic with me. And you haven't even bothered to understand what my circumstances are, where what you should be doing is saying, hey, let me provide you resources of food pantries that are in your area that you may not be aware of, but this is available to you. And I acknowledge, understand the challenges that you are having. And so whatever I may be able to help you assist with this, let me know. It may mean I'm writing a prescription for you to go to a special pantry where you are able to get these supplies and giving you the time in the day. But how do you talk to somebody and you don't have a clue about what their circumstances are in their home?
Yes, Tracy, I don't know if you have anything you wanted to comment or add to that. You may or may not. Okay. I will add that certainly I'm not the spokesperson to address policies and procedures at IU, but certainly in light of the Susan Moore panel review, there's been several initiatives that have been initiated, as well as ongoing programs to support and collaborate with programs in the community, such as the Center for Leadership Development and the Crispus Attucks Magnet School for Medicine that IU is very much involved with, and they serve to encourage and support young people of color.
So Lauren, one policy that we, a number of us did about 3 or 4 years ago was that how payments are given to family practice and OBGYN providers for doing prenatal care. They used to be able to give them a lump sum of money, and they give it to them up front to take care of that patient. But once they got that lump sum and they got it in the first trimester, the providers, there was really no incentive by the provider to try to make sure that their patients are coming in. So two things that we did to address healthcare was that also, so we said, you got to change how the reimbursement is provided to the provider. You have to lay the reimbursements throughout the whole 3 trimesters of care and give the lump sum near the end, but based on if they've made so many prenatal visits. So that way there's incentives from the healthcare systems to try to get these pregnant moms in and have so many visits in order to get a higher reimbursement. The other thing that was a real blow to us for infant mortality in the whole state was some state legislators had stopped where you could go back 3 months prior and get enrolled for Medicaid. That had stopped. So providers are saying, okay, you're new, you don't have Medicaid, and I can't even get reimbursed for you from this first visit because you've not already been approved. We saw so many providers stop seeing patients because they didn't have Medicaid at the time of the first visit. So patients were coming in real late in the trimester. And of course, if you don't have the 6 or 7 visits that you need, you have poor health outcomes. So we were able, from a policy standpoint, we do a lot of education over at the state legislators to try to get them to understand. And so we were able to put that back in place. And so that's been really key. I think we're fortunate too that we have a health commissioner who may be OBGYN, so we can sometimes get a little assistance from the State Department of Health trying to push issues related to infant mortality, which has been our health department's primary goal related to this. But Tracy, I got to tell you, postpartum depression has really hit us heavy related to that. And so what issues we need to do to address that is huge.
And I think that your points about trust and relationship are so important, and you have to build those relationships with patients before they become pregnant to impact infant mortality and maternal mortality. That's why, as you point out, in rural areas or in poor access care areas where there's a paucity of care providers, it's important to have programs such as I know that are developed through the county health department as well as the State Department of Health, to have programs that help promote relationships between care providers and women as well as men, but women in the case of maternal and infant mortality, as well as improving their health before they become pregnant, and having that access and that relationship where they feel comfortable presenting early in their pregnancy for their prenatal care. Dr. King, can you also discuss some of the steps your organization has taken to expand leadership opportunities for ethnic minorities in health services and management?
Well, I think the critical thing is that one of the things that I noticed when I first got there, we did a lot of internal posting and job postings. So if you don't have a large number of minority employees, there's no way they're going to advance. So I think the critical thing for us was, how do we partner with different communication avenues for people to have a better learning of our job postings? So being able to partner with racial and different ethnic minority organizations to say, hey, we have this posting, anyone interested in this? We've actually, even with some of the faith-based churches, have told them of positions that we may have available that has led to us having a higher higher minority applicant pool. But I also like where we've been involved with Lean Six Sigma, where we have gotten minority applicants through a process of leadership and projects where we've partnered with them, where they've been able, through these projects, from a leadership standpoint, expand their opportunities, but they've also developed some skill sets that makes them a greater, better candidate for positions of supervision or leadership within the organizations. For example, Eli Lilly allowed a number of us to go over to their facilities and do a Lean Six Sigma project. But we've also had projects where we've had minority candidates do Lean Six Sigma. And we've tried so employees in our department, if they were interested, have said, we will try to sponsor you. So we're starting a new program that we started this year that we're considering continuing next year. So, and then I hate to say this, people need mentors. You know, I can't get into this committee unless I have a mentor say, hey, this person is great. I think she's a great candidate. Let's invite her to participate in this. So there are tons of committees in our hospital or healthcare systems, but unless you have a mentor saying, I think you would be great in this this area, you'll never have an opportunity. So I had a great mentor who was just phenomenal in helping me with my career. I'm not apologetic. He was a white male who just was incredible for me as a mentor, helping to say, I need you to be involved in this, but he picks up a phone and makes a call. And I'm able to get on a committee that I otherwise would not have had an opportunity, couldn't do it on my own. So sometimes we may have to be a little bit aggressive. We may see someone that, wow, I've got a lot of respect for that person. They're doing an enormous job. I wonder, would they be willing to, you know, every once in a while, give me some advice? And sometimes it's difficult because those individuals are so busy, but you might be lucky and someone might say, you know, just go and ask. I'd love to know, just from a career standpoint, what do you think I should be doing? This is what I'm thinking about. Do you have any thought processes for us. So all of you on this call, you should have had at least one protege that you're promoting and enhancing in order for them to advance their career.
You know, I think your point is so well taken. I think that for the health administrators or other people in leadership, it's important to, as Tracy sort of pointed out, examine what might be your implicit biases and to realize that what your prototype is of a successful leader in your programs may not fit the prototype that you're used to. I often look at the NFL for those kind of examples of how the barriers had to be broken to break the prototype of what a quarterback should look like, what a head coach should look like. And so I think we need to examine that in all aspects of life. So I don't know if you have anything to add to that, Tracy, or not. Okay, thanks. Let's look at the unpredictability and uncertainty of the COVID pandemic. It's created a number of concerns and obstacles for healthcare providers and for patients as well. It certainly created concerns and alterations in the way OB-GYN and maternal fetal medicine specialists provided care for pregnant patients. We looked at reduction in the number of routine visits for uncomplicated pregnancies. We offered and utilized telehealth, which was not much used in obstetrics for patients. We looked at restrictions in delivery and visitation policies, as well as collaboration amongst a variety of healthcare providers and services. Some of these services, as I think Tracy and Dr. Kane have pointed out, have proven to be beneficial for healthcare and healthcare delivery, and certainly will expand beyond the pandemic. During this pandemic, though, COVID infection, fear of COVID infection, serious illness or death of loved ones from COVID infection, fear of getting COVID if I come to the hospital, fear of getting COVID if I come to a clinic visit, isolation or quarantining due to concerns of COVID infection, loss of employment, as we pointed out, or the fear of loss of employment if I don't go to my job, but the fear of getting COVID at my job, childcare issues, home schooling issues related to COVID and the pandemic. All of these factors have played a significant degree in the degree of stress that women and children and people of all kinds have expressed and experienced. Tracy, I wonder if you might speak a little bit to the concerns related to these stresses and how we've addressed them. We certainly know, I know that stress can be a factor in preterm labor and preterm delivery, and then all the complications that go on from there, as well as other health concerns. And could you speak to that for us for a little bit?
Absolutely. So the pandemic has shown so many gaps. It has also just shown us how much more stress pregnant and postpartum women are under. I would say in my program alone, I'm seeing 3 to 4 times the referrals. So possibly prior to the pandemic, a mom expresses that she's dealing with some postpartum depression in her OB visit. The OB would have given, some information, possibly a list of therapists, and maybe started medication. And so that has really changed because the therapists aren't available, especially if we are dealing with Medicaid. And so more and more OBs are referring to my program. It is a one-person program. And so obviously that I have felt that strain for sure, just having to be more, I had to change the way I worked, quite honestly, quite a bit actually. And so we'll talk about that a little bit later, but just the gaps that are existing in the mental health system overall, but especially in perinatal mood and anxiety disorders. And that's what I can speak to. Again, the numbers are up. The severity of illness is so much higher than it was. So again, it might have been baby blues, low-level postpartum depression, some anxiety, these women are having to worry. I mean, I say this every single week in my support groups. The weight of motherhood has gotten so heavy in the last 2 years. It was already really heavy. And I just feel like there's not one thing that's simple about it anymore. They are just stressed from the minute they find out they're pregnant, whether this is someone who has an unexpected pregnancy or has planned a pregnancy for 5 years. They're terrified to be pregnant during a pandemic. They are terrified that their doctors won't be able to see them. They're terrified about not getting ultrasounds because, right in the middle of that pandemic, we weren't seeing patients for a little while. So there's so much anxiety and it just builds. And again, with the underserved population, we're already dealing with trauma, probably from the time they were in their own mother's womb. So we've got all that to deal with anyway. There comes the pandemic, and this population has just really been hit super hard. So all that to say, that leads to the higher severity of illness, shows then, okay, what are we going to do when we see a mom who's suicidal or who's having really active intrusive thoughts? Unfortunately, there's a lack of education about perinatal mood and anxiety disorders. And so we see moms showing up in ERs constantly with mental health issues. And again, if there's a provider or a nurse or a social worker who has not been specifically trained in this area, you can see how an intrusive thought can become neglect and how DCS could be called during that time. And again, if we talk about this compounded trauma, we are doing nothing but adding to that with not having that education. We also have a significant problem with intensive inpatient program and the lack thereof. There is nothing in Indiana for a woman who is suicidal due to perinatal mood and anxiety disorders. And so we send them to mental health facilities where they are forced to separate from their newborn baby who's breastfeeding. They're told to dump their breast milk down the toilet. Their illness is just absolutely exacerbated with the separation alone. One can only imagine. And this can be for up to a week where there's no visits with babies. There's no opportunity to pump breast milk. The mental effect of stopping breastfeeding so suddenly, that can really make her depression and anxiety much worse, much quicker. And then they change medications. They're just kind of flying by the seat of their pants a lot of times, again, with a lack of education. And these women are put in psych units. So we have a significant mental health patient who's dealt with bipolar disorder their whole life, schizophrenia, and they're rooming in with a mom who has postpartum depression. So their anxiety is going up. I've had women tell me it's like I'm in prison. No one talks about postpartum depression. They talk about their long time or their lifelong mental health issues and their suicide attempts. And here I am having an intrusive thought, and I'm in here. The support groups don't talk about postpartum depression. They're in there with drug use history, criminal history. These women are terrified. And so they're coming out of that with post-traumatic stress disorder. And if she doesn't take her life, she's then left with all of these things too, because we do have that as well, where women come out of these facilities and are so hopeless that it leads to infanticide or suicide or both. And so that's the kind of issue that this pandemic has really shown such major gaps in.
I can certainly totally relate to that. And any woman who's gone through breastfeeding knows that that's not the easiest thing in the world. That doesn't go smoothly without, and it can be stressful in and of itself. And we push it appropriately, but push it very much in obstetrics and healthcare that's what, if you really care about your baby, that's what you'll do. And then when you can't do that, you feel like a failure. We also, there's been stress that I've seen in patients related to, should I get this vaccine? And there are valid concerns that they have related to how the vaccine's rolled out and the information available to them, and the stress of who do I trust, as we talk about trust in relationships again, about getting vaccines for COVID and other things in pregnancy. And so you're so right. And I feel, quite frankly, as a trained maternal fetal medicine specialist, that I do not have the expertise to give the proper care for perinatal mood disorders. And we need more, as you point out, more providers who can address these serious issues. Dr. Kane, do you have anything to add to that?
Nope.
Okay, then we will move on. Dr. Kane, can you speak to some of the IT or technological assistance your organization has provided for employees to provide services during this pandemic and how it's impacted delivery of care through your organization?
So one, I think, from an IT standpoint, we really had to order more of those mobile modem devices for people that we do a lot of field work out in the field. And we had this episode where we had a ransomware attack at one of our hospital systems that impacted us. And so we didn't even have email. So by able to provide all these individual little modems available for folks and also for those who didn't have laptops, providing them new iPads in order to work from different delivery sites, especially at home. I think that was key, providing supplies, also making sure that for our providers, we had to give them additional time in order for them to sometimes see clients based on our IT issues. When we looked at the pandemic, we had to also, in order to help provide services, starting having mobile units doing vaccinations as well as testing in regard to the coronavirus. So, for example, we have a mobile unit down there at the bus stop, Julia Carson's transitional bus stop, that's there every day, but also hitting different places based on our GIS map, showing where we were having major outbreaks. So we would set up these mobile units to do vaccinations and testings in those areas. And the other critical thing is we had no clue how many people do not have the ability to read. We were patting ourselves on the back and said, oh, all this information we have in different languages, but for third grade level, and had to have 25 of the Latino X population organizations meet with us to say, hey, we have such a huge influx of people who just cannot read at all. So we had to establish a call center from like 8 to 7 Monday through Friday and from 8 to 12 on Saturdays to address services, questions and answers. But the general public want to have someone as a healthcare provider to answer their questions. Well, tell me about these boosters, shots, and who should get the additional shots. Restaurants calling us, had to have a special line for restaurant customers because, what kind of guidelines do I have to have in my restaurant? And then sometimes, unfortunately, you get those people weren't happy with our mask mandate, but those were just some additional things that we had to put in place that otherwise it would overwhelm our staff if we couldn't pull away a lot of people calling with questions and concerns in order to free up our staff to carry out their services.
Well, thank you. I think we certainly have covered a wide range of topics at this point. Before we run out of time, we want to allow time for questions and answers. I'm going to turn this back over to Rodney to address some questions. I certainly want to thank everyone for the opportunity to be here. I know the panelists, I've enjoyed talking to them and we've enjoyed being a part of this presentation. I'll turn it back over to you, Rodney.
Thank you. So as Dr. Dungy-Poitras just mentioned, time for questions and answers. So if anyone has any questions, please unmute yourself and simply ask your question. You can also type in your message in the chat box and I will ask your question for you.
Rodney, this is Nicole. I'll ask a question. So a lot of the conversation, especially around maternal health, has been around those that are underserved and those that don't have resources. But we've seen where we've even had Black women physicians who have lost their life, and they have access to resources. They have good insurance. They have great education, but still, you're still at risk as a Black educated woman. And just wanted to speak to some of those barriers, or why our panel thinks that is the case for those who do have access, and some of the things that we can have our audience learn from that.
Well, I'll certainly say that, as Dr. Kane pointed out, the social determinants of health are very important in infant and maternal mortality, and that you're absolutely right, Nicole. Black women, educated Black women, are at more stress than uneducated white women in our society, and that we have to actually be frank about it and say that there's structural racism going on that affects the well-being and healthcare of women, and that's why there's such a disparity in healthcare. So, attaining a high level of education is not protective against some of the adverse effects and outcomes that can be associated with pregnancy, morbidity, and mortality. And if you want to read up on the concept of weathering, that helps explain why some of those increased risks occur. Weathering is a concept where there's chromosomal abnormalities, or there's actual defects in the telomeres of chromosomes associated with stress in life. And that on average, a Black woman is genetically 7 years older than a white woman of the same age. And that's regardless of education level. And as you may realize, or other people who are people of color at higher educational levels, the stress does not decrease just because you've attained more education. And so those effects can be worsened, and that we know that things like preeclampsia are more at risk in women who are older. Well, if my genetic age is older, then my risk is older. And so we know that those are all factors that play into play into maternal mortality. And if I have to deliver early because of a maternal condition, or just preterm delivery and labor can be associated with maternal stress, then I have the prematurity complications for my infant that would not be attended to by the same, a white woman of the same age and education level.
Rodney, you have another question on there, the chat, I believe.
Thank you for catching that. This is from Dr. Epps, or maybe from some of the MHA students that are with her. I want to give them a little shout out. Are you encountering any particular issues around LGBTQ plus pregnancy disparities?
So I'll answer the one about the LGBTQ question. One, we don't always have enough providers who know how to even do a physical examination and obtain clinical specimens related to whether you're transgender or even a member of the LGBTQ group. And so that's always an issue. I want to go to a provider that I know that's competent, that knows how to do a physical examination. And if they have to collect clinical specimens, they know how to do it. And so we don't have enough providers that I frankly believe that have been trained in that particular arena. And so the other thing is always, I think, from the pregnancy disparities, I think we talked about it a little bit, but one, not recognizing realistically what their circumstances are and having communications related to that, and having to wrap around services that they need, whether it's postpartum depression, other services where they may have a food insecure environment. They may need support from an economic standpoint. They may need childcare support. Those are major barriers that we see higher in some settings. So I don't know, Lauren or Tracy, you may want to add more.
I'll add something, and then maybe Tracy has a component that can add on to this. I will say that in the population that I serve, when patients come to me with that community who are pregnant, they often have gotten there through IVF or artificial reproductive techniques, which in and of itself increases the risk of pregnancy, but also they don't fit the prototype of the typical pregnancy couple that we expect to see. And sometimes they feel marginalized by the care providers or people taking care of them. And they may not, I don't know, Tracy, if you ever come across any issues of how they don't feel like they fit in or are comfortable approaching care providers. I certainly have had anecdotally patients present to me and say that they were happy that they didn't feel like they were different when they were in our office. But
I think the other issues is that when this first started, what appears on the birth certificate, what's allowed to appear on the birth certificate. We had some legal challenges initially related to that. So they have a whole host of issues that we take for granted that people may not even be aware of.
At IU Health, we did see a need for LGBTQ support groups. And so we have started one of those as well for moms and partners, whoever wants to come in, so that they don't feel like they don't belong. Again, we just want everyone to know that there's a support group for them. Through this pandemic, I think support groups, the need for them and the reward from being a part of them, just having that connection has been massive. And so I think it's great that we have looked into that population as well and trying to make sure, because pregnancy and the postpartum phase can be even more complicated when we're dealing with those issues. We want to make sure there's a place for that as well.
Mm-hmm. And Ashkenazi Health has a special clinic that really emphasizes and specializes in this area that a lot of patients partake of those services.
Well, I have a question that I'm going to ask. And then again, if you have any questions, put them in the chat box or unmute yourself like I'm doing right now. So my question is, as a non-clinical administrator, what are some things that I can do to impact equitable care? Because I know a lot of times as an administrator, I get into these routines like doing my work in a way that's efficient, but still effective. And so how can I incorporate diversity and equity into that?
I think you have to do, you have to look at sometimes somewhere, I believe, of doing some focus groups. I know a lot of people do their patient satisfaction surveys, but I don't know that it always picks up those nuances that you really need to know in terms of how you might make changes. And I think just periodically, I think you need to talk to the very people you're trying to influence. When you just only continue to talk, I think, to providers and executive staff, you may sometimes miss the boat. And so I think we need to have some more candid provider-patient interactions about, from the patient standpoint. Is this a shared decision-making related to what's happening to my care? Are you always telling me what to do? And I don't feel you're listening to me, okay? I don't feel that you trust when I'm telling you about my body. And I feel I know my body better than you do, but I don't feel you really are listening to me. How do we get the shared decision-making where we can have optimal care? And I just think periodically, I've been in those positions. I hate to say this more than I want to say, where I've had people come and say, hey, your services are the pits. You design your services more for your staff than you do for us, okay? And hey, that's no way to do business. I mean, they've told me a lot of stuff I haven't wanted to hear. Okay, sometimes, but you won't get better. And sometimes you just got to grit your teeth and say, hey, I wasn't honest. I wasn't aware of this. So I think we have to do a little bit more of that in this day and age. And then you guys, because you're executives, even though you're non-clinical, you have unique skills that we don't always have, where you can help put delivery systems together. And you can integrate services in a way that we don't always have the ability to do, but you have the ability to do it. And so that's where we need you to focus on. What services needs to be integrated so that it's seamless? The communication is there, okay? And we're emphasizing our best strengths of the services that we are collaborating on. And then we're always looking for the best of the best. So how do you share the best of the best practices out there with everyone so that all benefit?
I will say that I think in any team effort, and that includes from the patient to the administrator, this is a team where our goal is to give the best care that we can give and have the best outcomes. That trust and relationship building is a key component. It has to be intentional. It has to be ongoing, and that all good teams review the films, even if they won the game, to see how they can do things better so that they can win the championship game at the end. And so I think it's an ongoing process. It's ongoing with everybody has value, everybody has input, and a good team is really hard to beat.
And I would just say to that, Rodney, that if administration sees gaps, that they just really do what they can to spearhead, things to fill those gaps. The need is there, maybe not working so much in silos, working more together. There's so many champions, and I'm talking about PMADs again, perinatal mood and anxiety disorders, but there's so many resources, but no one seems to really be working together to figure out how are we going to create that intensive inpatient program. We're all going to, have different, ways to the same thing. We all know it's there, but I just feel like we need to work more together. And in order for someone like myself to get to that point, I need the help of administration. I need their passion, their advocacy, and their listening ear to say, hey, there's a gap. Will you help me fill it? Because I can't do it in this position. So that would be my answer to you.
And my last point I want to say is I'm excited about this chapter and the new direction that you're going to making it more robust, because you have the opportunity from hearing from different spheres, folks being affiliated with different organizations, to learn about what are some innovative new best practices that they're implementing, that everybody can hear about it and try to learn more and decide where, boy, is this something I would love to adopt at my practice, my location. And that's why I think your organization here is so critical. You have the ability to showcase that in meetings and future events that you have.
Thank you. Thank you. Definitely appreciate that. We've done a really, really good job over the years in bringing like a diverse set of topics throughout the year, and diverse panelists ranging from physicians to nurses, clinicians, CSWs, and then obviously hospital administrators and educators. And so definitely appreciate your comments and your compliments. Definitely appreciate that. And with that, I will close it out. This has been a phenomenal program. Some takeaways that I had from this include, this one was kind of an eye-opener, a shocker, but Tracy, thank you for this. The severity of illness and anxiety in the underserved population has increased during the pandemic, which I think I assumed, but I didn't have that assumption, at least with this specific population. So if I heard you correctly, I heard, given the lack of education, about perinatal anxiety, the risk of harm to the underserved women with mood and anxiety disorders and postpartum depression. It's terrifying. I was eyes bulging out of my head when I was hearing you share some of those stories. So thank you for that. And I also heard a call to action to everyone that's on this call. Heard Dr. Kane mention that sponsorship and mentorship is key. And the call to action that I heard was that everyone, I think I saw a finger point too, everyone on this call should have at least one protege that they are developing. So that is definitely something that I will take to heart, and I would encourage you all to do the same. So again, thank you for this program. I know you could be anywhere else in the world, but you're here with us, and we definitely appreciate that. I also want to give a special thank you to our IHEN administrator, Corey Josie, who does so much of our behind the scenes work that makes this chapter run smoothly. I also want to say thank you to our IHEN programs committee for putting in the work to make this program a success. A special thanks to Jacob Butts, Kylie Winecki, and Savali Badu on the programs committee. And I see some of you are joining here today too, so definitely appreciate your time and your efforts in making this a success. Before we close out today's meeting, be sure to complete the evaluations on today's program, and I believe there will be more on that later, so I will leave that for our ACHE representative to address. And I'd like to highlight some of our 2022 programs that we have coming up down the pipeline. We don't have dates just yet, but I see that's being shared on the screen. Some of those that I want to highlight include and I know you guys have heard about the Great Resignation. It seems like everyone's talking about that, and we are going to bring a program to you in 2022 about that. RN and clinical staff retention and turnover. That is what we are going to highlight. Big issue for practically every healthcare system in the country. Another one relevant for practically every health system in the country, managing your clinical supply chain. The promise and perils of precision medicine. We're doing some work on that. The exact date to be determined. Indiana Innovation and High Performance. That's the HEPE Summit that typically occurs in the summer. And so be on the lookout for that. The specific programs within the HEPE Summit that we will be involved in include Building the Hospital of Tomorrow and Green Hospitals in Healthcare. You will be seeing some information about that in 2022 that's forthcoming. We already have our speakers identified for one, if not both of those sessions. So great work being done on that. IHEN annual awards that typically occurs in the fall of 2022. The exact date still to be determined. Understanding implicit bias. We will have an event about leading information safety. Dr. Kane mentioned ransomware attack, and it just seems like that's the new state of affairs in this day and age. So that's going to be a big ticket program that we are looking forward to as well for 2022. So great lineup of programs. In addition to this, I also want to highlight that we have a podcast coming out. So be on the lookout for that. We will advertise that through LinkedIn, and we'll be sure to send emails out to you all. And Dr. Antoinette Epps will get in front of the MHA program and advertise that to you all as well. We also have, I feel like I'm forgetting something, Corey. Career development. We have a career development series that we are going to be bringing to you. This will be our first time bringing that. We're excited about that. We have an executive coach that will be leading those sessions. The first one will be in spring 2022, and we will have 3 sessions that will be brought to you. More to come on that, but just wanted to make sure that I took some time out to advertise those things. All right, again, thank you for your time today. We value your membership, and I look forward to providing these great opportunities to you next year, and looking forward to continuing to invest into your professional development. With that, I will hand it over to Vishwa from ACHE for credit reminders and a final send-off.
Thank you, Rodney. So on behalf of ACHE, I want to thank everyone that helped plan today's session, including our moderator and panelists, and lastly, all of you for your participation. I did see in the chat, we are having some issues with the evaluation link. I'm trying to locate the current link and working with my people back here at ACHE. So it will be updated in the system as soon as possible. And I will also send it to our coordinators so for the event, so keep an eye out for that, but you can access it in your learning management system on the My ACHE page. So please keep an eye on that and fill it out. I'm so sorry about the hiccup in that sense. That's also the same location where you'll be able to access the recording for today's event within approximately 2 business days. And then for everyone who attended today's event in its entirety, you'll see your credits posted to your account within 2 weeks in the My Education credit section. That concludes our session, which is copyrighted in 2021 by the American College of Healthcare Executives, all rights reserved. Thank you, everyone, and have a great I guess not weekend yet, but looking forward to a good weekend.
And have a great holiday season too. Thank you.
Thank you.
Be safe out there.